Now it's my pleasure to turn the stage over to Russell Hertzberg. He's the CTO of Briotix Health in Colorado. And Russ, are you there? There we go. So if you could try and share your slides. And Russ will be talking to us about war, pain, and AI, use cases from the US mental health and chronic pain data. Or your title here is slightly different, Declining Health from Aging.
Yeah, I should have finished that synopsis. My bad.
Okay,
so
no
I'll
problem.
brief.
I'm sure you will allude to war and pain as well, and it's quite relevant.
No, there's some discussion on pain and the impact of the correlation of pain actually to different mental health problems. There is some data on that. But my name's Russ Hertzberg. There's a link to my profile. I'm the CTO of a $100 million healthcare provider, health tech company based in the Denver, Colorado area called Briotix Health. My own company is called JCloud, and I've been active and working with Svetlana for about 7 or 8 years now across a couple of different activities and efforts. So I'm going to talk today about declining health from aging broadly and kind of wrap up the discussion with this concept of longevity lab, both longevity lab for each of us as individuals, and then longevity lab in the aggregate. What does it mean for aging populations? Got a lot of different interesting data in here. I want to also mention that I'm a very active leader of machine learning projects in occupational health and safety in the USA, and that we are now in production on a first decision tree machine learning model that's predicting claims for a Fortune 50 USA customer that has almost 1,000 locations and hundreds of thousands of employees. So that's a quick overview about who I am and my involvement in the topic and why I'm here today. I need to move slides forward. Here we go. So as always, I create an agenda. I want to compare the European Union and the United States on the topic of AI. I've got an interesting comparison. I'm not pro-USA or pro-EU, but I can observe differences in the way AI and ML are progressing in what are really two different environments or marketplaces with different priorities. I'll then cover the USA data on mental decline and mental illness among the elderly, and a lot of this data is a real eye-opener, and I've lived through some of this personally. My father passed in 2018. My mother passed in 2022. And at that time, I was working on software applications for the long-term post-acute care segment in the USA market. So I kind of have been examining this phenomena both personally and professionally for quite a while, the decline of mental health in the elderly. I'm then going to look at a prediction model for mental illness crises. This is an interesting model that comes out of some joint research from the UK and Spain. Talk a little bit about severe mental illness in war veterans. The USA has some significant experience there. I'll look at not all the way back to World War II, but I'll look at the Vietnam era plus the more recent wars we were involved in the Middle East. And then talk about what our other speakers are going to discuss as well, is we're building AI ML data platforms. And I myself am very involved in trying to enhance the performance of human beings in healthcare. And you can enhance the performance, as our prior speaker mentioned, of both the patient and the provider. And that kind of leads me to this last slide that I'll cover, the longevity lab. So let's dive right in. In the USA, AI ML regulation is moving slowly and it's very decentralized. So CMS will worry about it for healthcare. EPA will worry about it for the environment, et cetera, et cetera. So each federal agency has its own mandate to either be aggressive about regulating AI or do a little bit or do nothing. In addition, there are specific states that have domain and purview over potentially regulating AI. And so you have states like California that are likely and are already being more aggressive. And you have a lot of other states that will be very loose or do nothing at all, like Texas. That's just the reality of the US situation. Of course, USA investors are in love with AI and ML. A lot of them see it as huge boosts to existing investments. They also see big new investment opportunities. So there's a massive amount of money going into AI, ML companies, research, technologies, vertical industry type approaches. We'll talk about that. The EU side has a centralized regulatory authority. It's moving very rapidly with regulations. We've already begun to see and hear the impact of that in the presentations today. It's implementing the legislation at a rapid rate. There is some significant legislation already approved, and some of the legislation involves some big interventions in AI. And so that's a fundamental different climate between the USA and the EU in terms of regulation. Aggressive, fast-moving regulation coming from the EU, very decentralized, limited regulation so far from the USA, but a tremendous amount of money aimed at driving innovation.
Russ, I think you've muted yourself.
Sir?
We don't hear you.
Am I back again?
You're back.
Okay, apologize. Yeah, that a couple different controls I'm juggling. I'm good now though. Okay, so big investment in the USA. Let's be specific. In 2024, 70 to 80 billion dollars went into new and existing companies to fund major AI ML projects. One of the biggest, probably the biggest, is this platform called XAI. It kind of raises the ante on the drug discovery AI ML investments in silico medicine and Zara. That's another company that was funded in 2024. This is creating a platform to actually accelerate human scientific discovery. Huge investment. And then we have some very interesting applications coming out of the provider setting. In this case, an acute care organization, Cedars-Sinai, has created an extended reality artificially intelligent ally, or Zaya, and it's this, it's an avatar type consultative AI provider, healthcare provider, basically that humans work with or potentially work with or opt in to work with when they come into Cedars-Sinai. So some very interesting stuff going on already in healthcare with ML and AI. And then on the EU side, some very interesting interventions. Just to give you an example, Parliament's priority at the EU level is to make sure that AI systems are safe, transparent, traceable, non-discriminatory, and environmentally friendly. The environmentally friendly one is maybe one of the biggest challenges, because I'm sure many of you realize that to do all the computing required of big AI ML models requires more and more data center infrastructure. And I think the domain of making data center infrastructure more environmentally friendly is kind of a different problem in some ways. It's an energy, cleanliness, safety problem. AI may help with it, but it's kind of qualitatively different. So this EU priority is a very broad, and I got into the review of that that legislation in a little more detail and noticed that, an unacceptable risk, a thing that's not allowed in the EU, is real-time and remote biometric identification systems. And here in the U.S. and in other parts of the world, we're now involved for purposes of security and to avoid massive growth in fraudulent accounts, both in financial systems and in social media, with what's called liveness detection. And, the ability to compare a photograph of a person or yourself from a government ID, like a passport, to a 10 or 20-second liveness detection video. And extremely necessary kind of authentication and security technology that also has a lot of military applications, including applications that can affect life and death in the short term, where there are some hot wars going on, but that type of technology is banned by the EU. So there's some interesting things going on in this regulatory environment relative to innovation that I think we should all think about.
Russ, sorry, you're muted again.
Yeah. All right. This will work better. I was trying to monitor two things at once. Okay. The number of Americans aged 65 and older will increase from 58 million in 2022 to 82 million by 2050. That's a 47% increase. And what that means is, if you look at the total USA population, it's a 6% increase in the total USA population that's over 65. Those are huge numbers. Older people more frequently have chronic pain. 60% of those aged 65 and over reported they had chronic pain, compared to 26% in the age range 18 to 24. And then as a result of things like chronic pain and just aging in general and chronic illness, 30% of older adults in the US are on lots of, are prescribed a potentially inappropriate medication. So every day, 750 older people are hospitalized due to serious medication-related side effects. So, mental health challenges in the elderly, alcohol abuse, poor diet, chronic pain, reaction to medication, long-term illness, just aging, dementia, Alzheimer's, other diseases that affect mental health, physical disability. And then you have incidents and events in life, loss of loved ones. So these are all the impacts and challenges for mental health in the elderly. Data sets and AI ML models. So as you look at the domain of the problem of, okay, well, how can I improve mental health care in the elderly? You need to understand the context you're in. So I'm in a private business context in one sense, in that, I work for a company. It's investor funded, but it's also owned by some of the executives. And, we have a collection of mostly other businesses as customers. And so we're custodians of their occupational health and safety data. And when we go to try to deliver better occupational health and safety programs to them, we're really looking at what data can we curate that is publicly available? What data do we have from that client that we've generated as we provide to them occupational health and safety services? And then also, what data do they own from other sources, maybe other providers, that they can basically assert their rights to the fact that it's their data. And so we're really building private data warehouses on private cloud infrastructure to help them deliver better workforce care. So there are some public data sets that are obviously of interest. In the US side, the CDC has a behavioral risk factor surveillance system. There's a link to that. There's a Substance Abuse and Mental Health Services Administration, SAMHSA, which also has some specific elderly data that's very interesting on substance abuse. There are other entities. Universities are always great. Health systems, other healthcare providers. And then another big federal government agency here in the U.S. called OSHA. And we've been working with their data. And the good thing about SAMHSA and CDC and OSHA so far is these are entities in the USA that are committed to making their data available. Now, their data meets certain ethical standards already. It doesn't resolve down to individuals. It's all grouped by demographics and things like that. And some of the ethical questions that the EU is driving, and that the other platform we heard about is working on relative to large language models is very, very, very innovative. In my context of large corporations and us providing them occupational health and safety services, large language models are banned. These companies don't want any of their company business data being consumed by large language models. Unless the large language model is implemented, and they've chosen to implement it within their private data warehouse, private cloud environment. And we haven't seen much of that yet, but that could change. I'm going to show you a predictive ML model right now for crises in mental health. It comes from a UK and Spain research group. And they ultimately wound up using a decision tree voting model called XGBoost, extreme gradient boosting. And this is what that model looks like. And they're basically grabbing mental health data from EHR, EMR systems, doing some classification on the data, doing some time series alignment of the data, and then applying the XGBoost decision tree model to the data. And they wind up with the application or dashboard level prediction of future crises. It's not clear to me whether this particular model is intended to resolve down to each individual patient, or whether this model might resolve down to patients that have drug addiction or patients that have Alzheimer's, et cetera, et cetera. One of potentially many mental health diagnoses, right? But again, a very interesting application of machine learning to mental health scenario. This is, actually a research project. Let's shift over to the discussion on mental illness in USA war veterans. This is very high level. I did some more detailed diving into mass murder incidents committed by war veterans in the United States. There are quite a few of those. It's certainly nothing that I'm proud of as a USA citizen, but it's a reality that severe mental illness in war veterans is common. It's a very common problem. Post-traumatic stress disorder can last for over 50 years. There are all kinds of sub-threshold mental problems and mental illnesses among the war veterans, any of which can kind of go over the threshold of what is post-traumatic stress. And close to half of all war veterans have various symptoms of moderate to severe mental illness. Just a real challenging problem for all of us in this space. So again, what I'm involved in is overall responsibility for Briotix Health technology, which includes multiple new software development projects and maintaining existing platforms. I'm working in AWS and Python. I'm working in C# and Azure. I'm working in Zoho with a lot of our legacy stuff, lots of API integrations. And our first data warehouse offering an ML model for our biggest client, who accounts for a very significant part of our revenue, is in production. It took about 2.5 years to develop. It is, in terms of characterizing development team effort and focus, the bulk of the effort is on the data ingestion pipelines. It's about automating, cleansing, matching, and just general hygiene of data, which is typically coming from multiple sources. Our first production decision tree ML pipeline has 4 different data sources. One comes from the company, one comes from one of our competitors, one comes from third-party claims administrators. And, so that's kind of, the nature of the beast. So combining 4 different data sources into a useful, workable data set, that's 70% of the effort. Data visualization, I gave you an example on the right of a cool Sankey diagram that's addressing reasons for readmission. Preventable readmission in acute care is a pretty big focus for some predictive ML efforts in the US healthcare system, because there's big potential cost savings there. The data visualization is about 20% of the effort, and the actual selection testing and then ongoing supervised learning and tuning for any particular AI ML model is only about 10% of your effort. So this is very interesting if you are thinking about or have started building an AI ML platform or use case. It gives you good guideline on where you're going to be focusing your effort and your time. I have read and have seen a lot of what I would call sensational fears about AI and ML eliminating workforces, and becoming racist, doing unethical things. I'm not really working in anything that's that broad and socio-politically impactful across all of the USA or all of the world or all of Europe or even all of one city. I'm very targeted on performance improvement of critical healthcare providers, or critical improvement in the performance of people who are managing the small to medium scale healthcare improvement efforts across a captive population like a workforce. That's the level at which I'm working on AI ML. So I'm not at that broad of a level. So I can't have too much commentary on whether what I'm doing is ethical or unethical. It's very focused on the problems of large employers and keeping their workforces healthier. That's kind of the level I'm working at it. So finally, to talk at the individual level, I think that as we all age, we are faced with something like this chart on the left, where we can age earlier biologically than our chrono age. We can age at about an average rate chronologically and biologically, or we can attempt to be a super ager, where our chrono age might be 66 or 75, but our biological age might be slightly or significantly younger than that. And if you can figure out a program via treating yourself as a longevity lab to achieve that super aging, or if you're blessed for one reason or another, or you don't have bad luck, that's probably where you want to be, because you'll have more productive years. You'll be able to contribute more doing the things you love. You'll be able to contribute more to the people you love. And so the idea of having a longevity lab mindset is that you act like a scientist with your own longevity. So you trust test results the most, and you run test results on yourself. You globally source the information and expertise about how to prolong your own longevity. There's all kinds of treatments that never make it into the United States because they're never going to be improved by healthcare insurance, and they're minimally invasive. And the USA healthcare system loves large-scale invasive approaches to healthcare for one reason or another. So you don't necessarily want to fall victim to some of the biases in your own system. You want to analyze and interpret as much data as you possibly can. And then, the last thing I'll say is what's possible with AI and ML is barely underway. So the impact of ML on longevity, the impact of ML on mental health in the elderly, we're barely scratching the surface. There's a tremendous amount of change and innovation coming. We can't even fathom the scope of what it might be at this moment. So here's some links and references, and that's it from Russ Hertzberg. I really appreciate your time and attention, and I look forward to questions in the panel.
Russ, thank you so much for an insightful, wonderful talk. I learned a lot, and